Welcome to Understanding Cancer. Today we're speaking with Dr. Denise Yardley, the Director of the Breast Cancer Research Program at the Sarah Cannon Research Institute in Nashville, Tennessee. Welcome.
Thank you.
I'd like to start out by kind of addressing the issue that I think a lot of women have when they're first diagnosed with breast cancer, which is some fear and some apprehension about the new diagnosis. When you first see someone in your office with a new diagnosis, what do you tell them?
I really tell them that this is the time to have the most hope with facing a diagnosis of breast cancer. The advances that have been made in the last 35 years have really changed the outcome for patients now facing a diagnosis of breast cancer. In fact, in the United States, there are over 2 million women that are living with a history now of a diagnosis of breast cancer. The death rate has continued to fall, and actually the incidence of the disease is falling. So there's every reason to have hope now when someone is given a diagnosis of breast cancer.
Now, some cancers require fairly immediate treatment.
Mm-hmm.
I think of breast cancer as being a little different in the sense that a lot of specialists are involved. There's a lot of care that needs to be coordinated, and people really maybe have a little more time to think about their treatment options.
And I agree wholeheartedly. It's a team approach for breast cancer now. We've got a lot of different specialists. We have the surgeons, we have a medical oncologist like myself, and then the radiation oncology physicians are involved. And I think the most important part when a patient's facing a diagnosis of breast cancer is to really feel comfortable with the disease and all the treatment options that are available so they can make the best decision. And often that means meeting with these specialists and really getting an understanding of what course of therapy they're about to embark on and what their choices are.
When multiple doctors are involved with a patient's care, it can be confusing for the patient.
Yes.
Trying to understand who their primary contact is and what each role may be. Is there one person in this group of individuals that is better suited to maybe be the coordinator of the overall treatment?
I think for most patients, it's actually a medical oncologist. I think we're able to direct the focus of all the different points of therapy for the patient and explain the significance of each treatment option. So when a patient sees a surgeon, she's able to talk about the different surgical options, but ultimately the patient comes back to the medical oncologist for long-term care. So I think most of the time we tend to help coordinate that. Our role does not take place until after the surgery, but we're able to really help patients kind of go through the chain of events in the different options to kind of get a sense of where they need to be and what therapy needs to happen first.
So when patients are first diagnosed, they're typically going to see a surgeon who's going to do a biopsy.
Correct.
At what point does the medical oncologist become part of the process?
There are two different points. A lot of times I do have patients that come right after the biopsy with a diagnosis of breast cancer. Many of those are referred from other patient contacts that really suggest to meet with a medical oncologist to get a sense of the whole issue at play. So all the different modalities of surgery, what my role might be in the patient, and as well as the radiation physicians. I'd say the other majority of the patients come after surgery, and I always limit my discussion until we have all the information at hand that has to be obtained surgically to make the follow-up decisions after surgery.
So that's really the key step in the process is the initial information gathering phase, which starts with a surgical biopsy.
Correct.
Are there any other tests that a patient typically gets once they've had the biopsy?
Once they've had the biopsy, depending on the presentation of the breast abnormality, if it's something that's small, identified on a mammogram, typically they go on to finish a surgical removal of the tumor, and that helps direct what other therapies and staging studies that we might need. For a patient that comes in with a more advanced tumor that may be something the patient felt may have some skin involvement, those patients typically get a biopsy that establishes a diagnosis, and then they're referred to me to help coordinate what the next best approach is, whether it might be chemotherapy first and then surgery, or if surgery still is the first primary treatment for the patient.
Well, Dr. Yardley, I'd like to thank you for your time today. I think our viewers will find this session most informative, and we look forward to having you back.
Thank you.